George, are you there?
Yes, I am. Good morning, Andrew. Good morning, everyone.
Hi, George. So look, it gives me great pleasure to introduce Dr. Javorsky. So George is our director of our heart failure and cardiac transplant unit at Prince Charles, which is the cardiac transplant service of Queensland. And even though we're all interested in transplant of this group, it's so interesting to work with people like George. And a lot of the innovations in cardiology have actually been driven by cardiac transplant units around the world. It's not just for the actual organ transplantation. A lot of the advanced heart failure management that goes with that has really, made a big difference in probably millions of people's lives around the world, not just those few who receive a cardiac transplant. So as we sort of push the envelope a little bit, we obviously get infectious complications, and Dr. Javorsky is going to talk to us about how we manage the LVAD and driveline infections pre-transplant, and he'll discuss what we mean by those.
Thanks very much, Dr. Burke. Thanks very much, everyone. Sorry, I can't be there. I'm actually on ward service at the moment, trying to do ward rounds. So I'm George Javorsky, as Andrew said. I'm just going to talk to you about LVAD devices. A couple of things I'll discuss. What are they? What are some common complications? I'll talk about a case A. I'll talk about LVAD infections and then the treatments as well. So ventricular assist devices are an artificial pump to help assist a failing heart. The main indications are bridge to transplant. For some patients, it's a bridge to recovery of the poorly functioning heart, and then destination therapy. And that's where people have such a bad heart, but they're not eligible for transplant, and they get an artificial pump to keep them alive. Main work on destination therapy is in the United States of America, with their health budget is where it is. Price per pump is about $120,000 per pump for the third generation pumps. I'm going to do a little bit of history just to walk you through some of the stuff that we've gone through over the years. First time when I started working in the transplant unit 20 years ago, we had these pumps, the Thorotec pumps, and they could either support the left side of the heart, both sides of the heart. As such, this is what they looked like. They were big, bulky pumps, and this was a peripartum cardiomyopathy lady who had biventricular failure, and she ended up with two external pumps. This one supplying the left ventricle, this one supplying the right ventricle. And you can see the exit site infections that were already there. These were big, bulky, and would often drag down a bit, and they needed support devices as well. And then they'd be attached to a cart, sort of like a shopping cart, basically, with a pneumatic pump to keep them driving. So we had those. I worked with those for about 6 years before we started getting some second generation pumps. And then finally we got to the third generation pump. This was the hardware pump. This is a magnetically levitated pump. As you can see, it actually fits just in the palm of a person's hand. This is the drive line here that goes to the patch pack outside of the patient. This part here attaches to the apex of the left ventricle, and this is the return cannula that goes up to the heart. And you can see on this diagram how it's attached to the left ventricular apex and then pumps blood to the aorta of the heart. This pump was around for many years, and then unfortunately Medtronic had to remove it from market about 2 years ago because of ongoing complications with it. So we now use the HeartMate 3 current pump. And again, this part attaches to the left ventricle, this part goes to the aorta, but this is the drive line. And this is the drive line that goes through the skin out to the patient. As you can see here, it goes out through the skin here to a controller, and the patient wears 2 battery packs as well. And certainly over the last 20 years, these devices have been miniaturized well. The ultimate goal would be to have transcutaneous energy transfer so that there's nothing poking through the skin. But one of the challenges with ventricular assist devices is these drive lines, similar like when on dialysis when people have peritoneal dialysis and they have the So what's happening around the world? So around the world, 25 to 80% of patients on the heart transplant waiting list may get transplanted off an LVAD. These devices, because they're metal, they're titanium, patients do need to be on long-term anticoagulation. Often they've had lots of blood transfusions, and therefore cross-matching the time of transplant can be quite challenging. It is a significant operative procedure, and therefore at the time of transplant explant, there's a lot of fibrosis and adhesions. The one that the surgeons did here last week, they said was probably the hardest because they spent 3 or 4 hours just getting through all the chest adhesions to be able to explant the LVAD before the transplant. And of course, they're expensive and there's a resource issue as well. What are some of the complications? Infection, and I know that's the purpose of today's talk, but some others as well: stroke and embolic events, bleeding, especially gastrointestinal and bleeding to the brain is an issue, and pump thrombosis, when clots actually forms in the pump itself and they stop. And certainly when people have repeated septic episodes, they are more prone to having pump thrombosis as well. And certainly death can occur. There's an increasing worldwide use of these pumps. In the United States, over 9 years, they implanted about 27,000 of these. The HeartMate 2, which was that was the generation 2 pumps, there was about 26,000 patients with those. Heartware had implanted over 10,000 before they were removed from market. And the HeartMate 3, which is the ones we're now using now, had done over 20,000 implants by December 21, and that's only over the last 6 or 7 years. In the United States, up to about 3,000 implants are registered as such. The worldwide data is not totally available, but certainly it's growing in numbers per se. So how long can people live with these? Certainly in the United States, there are patients at 10 years. There's a patient in Perth that has had theirs for 8 years, and certainly the longevity of these will continue to increase. United States does implant a lot of these devices for patients as a last option for end-stage heart failure and not eligible for transplant, and they'll live with longer with those. And in the United States, the market is 81% of those are as destination therapy, not transplant therapy. So that's a brief introduction of what, where, and how. So I'll just talk about a patient, and which is not well known to the infectious diseases team at Prince Charles Hospital. It's a 49-year-old female patient who, in January 21, had a myocardial infarct in northern New South Wales. She was a late presenter and actually had an out-of-hospital cardiac arrest and developed significant cardiogenic shock. She was transferred to us here. The interventionist undertook an angioplasty to left anterior distal and coronary artery, but underlying this, she had severe three-vessel disease. Data echocardiogram showed that she had severe left ventricular dysfunction, and further evaluation found that she had non-viable myocardium. Because she was very sick initially and actually had a multifactorial respiratory failure and needed broad-spectrum antibiotics, including antifungals as such. But after she recovered for that and extensive evaluation from a transplant point of view, because it was assessed that she would not have myocardial recovery, then she went on to have a left ventricular assist device as a bridge to heart transplantation. That was the intention. The implant occurred on the 2nd of February 21. Unfortunately, a couple of weeks later, she got eosinophilic pneumonia drug reaction, most likely secondary to amiodarone. And so she needed methylprednisolone to have that under control. And also she had reactivation on a CMV infection and needed ganciclovir as well. Early March, unfortunately, had Enterobacter aerogenes and Enterococcus faecalis bacteremia, and had antibiotics for that, initially meropenem, vancomycin, then cefepime, and recovered and was discharged on the 18th of March 21. So she had a fairly complex history already post-implant. That's not usual for our LVAD patients to have such a complex history post-implant, but it does occur. In April, she had a driveline swab and had staph epidermidis, but unfortunately, she actually came in quite unwell and had an Enterococcus faecalis bacteremia in April. The CT abdomen did not show any intra-abdominal source of sepsis, and there was no evidence of endocarditis on echocardiogram. So she was treated initially with vancomycin, piperacillin, and then transferred to ampicillin. She lived in northern New South Wales. This was all during the COVID lockdown periods, which made life a lot challenging as well. And initially was around here with benzylpenicillin and ceftriaxone. She had declined aminoglycosides, so that was that plan for Baxter bottles over 24 hours, getting those antibiotics there. All of this was in strong consultation with the infectious diseases team, of course. That was followed by amoxil as a plan to continue amoxil until she got a transplant or her VAD was explanted as well. She was followed up weekly in our LVAD clinics as such. Unfortunately, in April, she also had a PET scan that showed that the distal part of the LVAD cable, there was a little bit of there was increased FGD uptake as such. So we were aware of that. Following the IV antibiotics, the peak was removed, but unfortunately there was some candida in that, so she got some fluconazole as well. And then over 22, 23, the exit sites had ongoing Enterobacter cloacae, and so she had treatments and then prophylaxis with amoxicillin and Bactrim as documented there. March this year, she had increasing abdominal pain, and so a CT abdomen had demonstrated a 60 millimeter loculated collection there surrounding the proximal cutaneous portion of the LVAD lead. And interestingly, while she was an inpatient, she had a popping sensation, and then there was a moderate amount of hemoserous discharge. Klebsiella pneumonia was isolated, and she was on IV meropenem, and she was in hospital for a little while and then was discharged to an outpatient program. And then she'd got the eretapine 1 gram daily on discharge for a longer period of therapy. These were the CTs, that's the driveline as such, but the collection around, again, here on the CT, on that picture there. And she had serial ultrasounds, and over a period of a number of weeks, we saw that the collections that were there started actually getting smaller and smaller. Fortunately, she also had serial CRPs, and the CRP did drop from about 90 down to 3. And then there was a plan to change it to oral Cipro, as well as augmentin Geofort for a shorter period of time and continue with Cipro as well. And so the question goes, well, it's now 2 years, how come we haven't transplanted her? Well, things are never straightforward. Unfortunately, when we look at what her transplant antibody profile is like, and we do what we call a panel reactive antibody, we like to see that number as 0 to 10% type scenario. Unfortunately, with all the transfusions, and she's female and has had a number of children, her panel reactive antibody now has crept up over a period of time up to 100%, which makes it very difficult to cross-match and close to impossible. We've actually reached out to the Sydney transplant team as well for help to try and increase our pool there, but that's difficult. So the other question is, can we immune modulate it and remove and reduce some of that antibody profile? And normally with immune modulation, you can look at plasmapheresis, you can look at using rituximab and other suppressive type therapies, but she's got underlying infection, and the risk benefit of that is also very difficult. And we also want long-term survival as well, and that can be quite challenging. So that's another challenge, and we've certainly been working closely with our immunology team as well as our infectious diseases team as well. So then they say, well, how about we just replace the LVAD? So I mentioned in my introduction that the hardware, and she happens to have a hardware LVAD, that was removed from the market the other year. And so the new HeartMate 3 is not compatible, particularly you can't just attach things straight forward, and it would be a major undertaking and very high risk surgery to replace the LVAD as well. So that's where we are with her. So if we talk about ventricular assist device specific infections, then there can be included, the most common ones are those involving the driveline. There can be extravascular pump infections, and there can be endovascular pump infections as such. The ventricular, there's also ventricular assisted device related infections such as metastonitis and infective endocarditis. And then of course, these patients are susceptible to any other infections as well, but we've always got the issue that they've got an LVAD in situ, and we've got to keep that in mind. If we break down what the data shows, like metastonitis is about 2%, endocarditis is only 0.1 to 1%, but driveline infection easily up to 12 to 35% of the patients. And bloodstream infections about 36% as well. So this is the exit site here with infection around it per se. This is a bit more infection and pus coming out as such that we need to do. And this is not our patient. This is a photo of someone who actually had a pocket site infection overall. This was not our patient. So incidence, as I said, some studies go up to 71% of driveline, some say 35, it varies. We certainly see, especially in Queensland's hot climate, that that's an issue. And then the extravascular pump infections are much lower, and certainly touch wood, I haven't had that risk factor here. What are some of the risk factors? Obesity, diabetes, previous cardiac surgery, and how you place the driveline. Our LVAD nurse certainly teaches our patients how to care for the driveline, and it's all done in a clean, sterile way, and they end up with a multiplex dressing over the driveline to try and keep it clean, especially as we know with the humidity and heat in Queensland, it's a much higher risk. And then we try and secure the LVAD line as well, the drive line, so it doesn't move around, because as you know, if they get trauma and move around, they'll predispose. So what do we commonly see? There's a lot of Staph aureus is the predominant component, and gram-negative certainly Pseudomonas and Enterobacter, and certainly they end up with lots of antibiotics over a period of time, and multi-resistance can occur, and fungal infections can occur, and that occurs much less common. I don't need to tell this audience how to undertake an assessment of people who are got infection, but certainly we utilize the echocardiogram department a lot and do a lot of CTs and ultrasounds as well. And then from a treatment point of view, like with this patient, can we get away with using oral antibiotics? Then we move on to IV antibiotics, and that's all in liaison with our infectious diseases team of what we give moving forward. Occasionally, we have to look at debridement per se. If they've got extravascular pump infection, that's much more serious, and then needing surgical drainage and evacuation and device replacement ultimately. And if they've got endovascular pump infection, then again, broad spectrum antibiotics and surgical management. But not everyone can have a device replacement, as I've mentioned. The elderly patients, a lot of these patients get sicker and sicker, and an operation would be too high risk. Urgent cardiac transplant, certainly in Australia, we have a way of listing patients for urgent cardiac transplant if they've got uncontrolled LVAD sepsis, and we've had patients that way, as well as interstate patients as well, and some of these patients end up needing to be palliative. Certainly at the time of when we implant an LVAD, we have an antibiotic protocol, and we generally use vancomycin, aztreonam, and fluconazole at the time of the implant as well, and we try and keep that as short period as possible. And duration of that, some centers only do 24 hours, some centers go to 72 hours, some centers go until the chest drains are out. We're trying to keep it down to about the 72-hour mark if we can. And that was, again, developed in conjunction with the ID team here. And then at the time of explant, when we do a transplant, then we tend to use a vanco, fluconazole, ceftriaxone if there's no issues. But if there's been a long history of various infections, then again, we'll modify those antibiotics to ensure that we cover any organisms that are present at the time, including those exit site infections as such. So look, this has been a quick run through of LVADs and some of the complications as such from an infection point of view. These are complex patients. Normally we like these patients to be a bit more straightforward post-op, but the case I gave was more extreme. It is very much a multidisciplinary approach across all the teams there. Removing the infected device is not always a straightforward thing. I'm very cognizant. I mean, I'm a cardiologist, and I know that when we have infected pacemakers and defibrillators, they get removed, the leads get removed, but the LVAD, because it's keeping these patients alive, because it's supporting the heart function overall, or taking over the heart function, it's not so straightforward. Heart transplant is ultimately a possible solution, but in the case I showed with her cross-matching is very difficult, and the solution's there. But ultimately, I actually have to say a big shout out to the infectious diseases team, who have worked very collaboratively with us over many years to sort through these patients. And without their help, we wouldn't be able to get the outcomes that we have. So thank you very much for the opportunity, and I'm happy to take questions.
Thanks, George. Not sure if you have any quick questions for Dr. Javorsky. If you just, stop sharing. Thanks, George. So do we have a national registry for these LVADs?
Yeah, look, we're working back towards that. So that's being worked through. The National and Organ Transplant Authority is now working through that. We have another registry for this. We were part of the International Heart Lung Transplant Organ Registry, but there were some issues that crept up 5 years ago. So at the moment, we're in the process of restarting that this year, and the National Organ Transplant Authority it's under that umbrella at the moment. So ideally, we need that, absolutely.
It's sort of interesting that the United States, I guess it's a strange word to use, destination therapy means you're having this until you die of your heart failure, as opposed to transplant. 80%, if I call that correctly, 80% of the LVADs are. So we wouldn't put an LVAD in someone unless they're a candidate for heart transplant. Is that correct? Or sorry, they might expect to recover from, say, a cardiomyopathy or something.
Look, ours is it's a funding issue. The US Medicare system gives every hospital $200,000 to put an LVAD in, and so their Medicare funding system in the United States facilitates that. And so their LVAD population often is patients in the 70 to 80-year range who are no longer eligible for transplant, but there's an opportunity to keep them alive for a lot longer. And so, their 80% is sort of the patients who are end stage heart failure. They're on all the medical therapy, and they're no longer eligible for transplant to keep them alive longer, and therefore they have that destination therapy arm. Our funding for transplant for LVADs is hospital based, not nationally based. So we don't get a $200,000 check for every transplant LVAD patient that we do, like the United States does.
Okay, thanks very much, Dr. Javorsky. Thanks for taking time out on your busy
Dr.
clinical
Burke.
service.
Appreciate it. Thanks very much for the opportunity.